Assalamu alaikum viewers. Today we will discuss dealing with the difficult pedicle here. We are performing a right-sided radical nephrectomy for a lower polar tumor in a young 26-year-old female. I have already mobilized the colon, and now I have created the window between the gonadal vein and the ureter. It is important to make the window lateral to the gonadal vein here, because as we know that gonadal vein is directly draining into the IVC, and a little bit of pressure can lead to avulsion of this vein from IVC. That's why it's important to dissect and make a window lateral to the gonadal vein, so that lower pole of the kidney can be mobilized. Here you can see the ureter. This is the ureter. So we are extending this window towards the hilum of the kidney, and you can see that gonadal vein is lying quite in a relaxed manner. But here you can see that a structure is coming anterior to the inferior vena cava and draining into the going into the kidney, and upon dissection we found out that it was the lower polar vessel, which interestingly is crossing anterior to the IVC, and you can see that there is this artery is accompanied by a draining vein, and this vein is draining into the gonadal vein, and then in turn the gonadal vein is draining into the IVC. So situation has got a little bit difficult here, because a little bit of traction on the lower pole is providing a stretch on the gonadal vein because of the vein which is draining into the gonadal vein. So it's an interesting anatomy of the pedicle here. So instead of avulsing, here you can see the structure going anterior to the gonadal to the IVC and posterior to the gonadal vein into the kidney. So this is a lower polar artery. So instead of avulsing the gonadal vein, we decided that we must deal with this pedicle. It will give us a dual advantage. Number one, a big portion of the kidney will be devascularized, and so there will be less venous congestion. And number two, we'll be able to handle the main pedicle. And another advantage is that the pull on the gonadal vein will be zero after ligating and clipping and cutting this pedicle. So what we have done here, as you see, we applied 2 clips proximally on both the vessels and 1 clip distally respectively, and we have cut in between them. So now the pull on the gonadal vein has come to an end, and we are proceeding towards the main hilum now, and dissecting the peritoneum from the vein, we found out that there was another vein which was draining from the kidney into the IVC here, posterior to the main venous pedicle. So now we are trying to dissect this vein as well in order to reach the pedicle. So the method here now is that the general rule is to clip the artery first and apply just 1 clip and dissect the artery enough just to allow 1 clip, so that the blood supply to the kidney is stopped and the vein becomes collapsed, and then we can clip the vein and then cut it, and then deal with the rest of the artery. So this is the plan now. So we are trying to find the artery here. We were happy that a big artery has been clipped and divided, so almost 60% of the kidney became ischemic. Here you can see the artery pulsating behind this accessory vein. However, we are still not able to identify the artery, so we decided to dissect around this vein, and maybe we have to clip and divide this vein as well in order to reach the artery. So the artery is, as you can see, at the tip of the ligation here. So we made a window. You can see a very thinned out base of this vein connecting to the IVC. Dissecting behind the vein so that if there is any artery, that will be isolated and will be easily dissected. But by the end, we came to the conclusion that we have to clip this vein, otherwise it won't be possible for us to clip this artery, and hence the progression of the procedure will be difficult. I have left some bit of tissue around the IVC. As you can see that the silicone isolation of the ligation is in direct contact with the IVC. So there might be some thermal injury thinning out of the IVC and hence rupture and bleeding. So this tissue which I have left on the IVC is helping to absorb all the heat and save the wall of the IVC. You can see the artery peeping out there. So as a general rule, the lymphatics around the artery are abundant, and once you are able to dissect more and more of the lymphatics around the artery, the length of the artery that you achieve is good enough, and you can then apply Hem-o-lok clips. So here we have applied a Hem-o-lok clip. We have decided to clip and divide this vein. The reason I'm not very happy about clipping the veins first is that at times the kidney becomes engorged, and the veins become so much engorged that it's then difficult to apply clips around them. In that case, we may have to apply intracorporeal or extracorporeal knots before applying the clips, or you can use a staple device as well. That's why I'm not very happy about clipping the veins first, but here the situation is different. We have already clipped one artery which has already reduced the blood in the kidney, and second thing is that we have found the artery, and we have also found that it's not possible to dissect this artery before clipping this vein. So we clipped it and then we divided it, and now we are doing the artery. You can see there's a main trunk which is coming behind the inferior vena cava, and then it is dividing into two branches in the shape of a Y. So we decided to dissect around the artery in order to achieve length and in order to make a window which is big enough to accommodate the application of Hem-o-lok clip. So the more lymphatics we divide, the more length we achieve. A little dissection between the renal vein and the artery. It is not without danger to grab the vein with the ligation. Here we applied this clip, so we are now satisfied. You can see the color of the kidney has changed. The vein diameter has become a little smaller, and the vein has collapsed. So this gives us some bit of satisfaction that we are going in the right direction. So then we dissect the vein completely by using the 10 millimeter right angle forceps. For all these steps, it's important to put in the right ports at the right sides. So it is a right-sided nephrectomy. So I put 5 millimeter working port on my for my right hand, and a 10 millimeter port for my left hand, so that the hemolog clip can come in a linear fashion towards the vein, and the 10 millimeter right angle is also coming tangentially for the dissection. If it was in my right hand, I would have been right over the vein, so it would have been difficult to apply the hemolog clips as well as do other dissection with the right angle. Another important thing is that do not cut the vein or any other vessel in one go. Just open the lumen half so that you can see if there is any bleeder. And the second thing is that we usually apply these hemolog clips after stretching the pedicle. So this stretching can be at times an overstretching, and then applying the hemolog clips. But after cutting near to the proximal clips, and this may lead to slippage of the vessel from the clip or the clip from the vessel. So we divide the vessel near to the distal hemolog clips rather than the proximal hemolog clips. You can see the vein, that there is a bit of lumen that we can see here. Yes, here, and there is a good stump. So if we cut near to the proximal clips, then there is a danger of slippage of the clips or the vein from the clips. So now the artery has also been completed, and we are cutting the artery near to the distal clips. Thank you very much.